Welcome, everyone, and thank you for joining us for another webinar from PRISMS. My name is Allison Stepanot, and I am a PRISMS board member, and I'm also an SMS mom. The title for our webinar this evening is Building Bridges and Navigating Adult-Based Healthcare for Individuals with Developmental Disabilities. This webinar is brought to you by PRISMS. PRISMS is an acronym for parents and researchers interested in Smith-Magenis syndrome. PRISMS is an advocacy, education, and support organization for individuals with SMS, their families, and the professionals who serve them. The recording of this webinar and all past webinars can be found on prisms.org under the Education tab. If you have a question for our speaker during the webinar this evening, you can type it into the Q&A box at the bottom of your screen. We will do our best to get to as many questions as we can tonight, but we don't always get to all of them. Tonight, we'll be talking to Dr. John Behrens. Dr. Behrens completed medical school at Baylor College of Medicine and completed residency in internal medicine and pediatrics at the University of Pennsylvania with Children's Hospital of Pennsylvania. He is currently serving as a primary care physician for adults with intellectual and developmental disabilities. Dr. Behrens is also a member of the PRISMS Professional Advisory Board. Tonight, he will be discussing the many challenges and barriers that make the transition from pediatric to adult-based healthcare difficult, particularly for individuals with intellectual and developmental disabilities. Hello, Dr. Behrens, and welcome. Thank you so much for being with us tonight. This is a topic we've had a lot of requests for, so thank you for sharing your insight with us. I'm sure you see firsthand how difficult the transition can be. I know we're all really looking forward to your presentation, so I will turn it over to you now.
Wonderful. Thank you, Allison, and thank you so much for having me tonight. I've really enjoyed my time as a PRISMS board member over the last almost year now, and I actually gave a similar version of this talk at the conference in Dallas this past summer. So I'm excited to share this talk again. And like Allison said, if there's any questions that come up along the way, feel free to add them to the chat. And if they fit in with, kind of what we're talking about, we'll try to address them as we go. And hopefully we'll have some time for questions at the end as well. So with that, let's get started here. And if we have any issues not being able to see my slides or the transitions, Allison, please let me know. So this talk is called Building Bridges, as was already mentioned. For a reason, there will be a few bridges throughout. I don't have any disclosures before we go along. So just to set the stage and to give a little introduction, this is a slightly old picture now of my team. And I'm at the Transition Medicine Clinic in Houston, Texas, at Baylor College of Medicine. You can see me in the back. I'm pretty tall if you've ever met me. But it didn't start here, of course. This journey of where I am today professionally started as a camp counselor. I was a recreational therapist in the summers during college at a camp where I grew up, having lots of fun with individuals with a variety of intellectual and developmental disabilities, including one or two individuals with SMS. So it's been a long journey, and I'm excited to share today some of the things that I've learned along the way from the physician side of things. So in terms of what we want to accomplish today and our objectives, the first one is just to review the lay of the land and the challenges that many people and emerging adults face during that transition period from going from pediatric to adult-based healthcare, especially those who have intellectual and developmental disabilities, which I'll abbreviate IDD for short as we go through the talk. Secondly, I want to describe the experience, at least of one clinic, that's my clinic, that serves adults with a variety of causes of IDD. And then using that experience, we will develop a framework for the healthcare transition process that hopefully our audience can take with them and be a starting point as people think about their own transitions in their own lives. And then we'll end by discussing a few unique health and life considerations for individuals with IDD as they reach young adulthood and beyond. So, building bridges. Transition, I think, is best thought of as a bridge. I really like this particular example of a bridge because it's really long. It's kind of nice when you look back at it at a very 50,000-foot view, meaning it's, sort of a positive thing, but it's a long process. And I think that's maybe like the key thing to take out of this picture is that transition is a process, and it's often a very long one, going from one side to the other. Sometimes we don't really know what the destination looks like, and that can be a little bit scary at times when we know that we're going somewhere, but it's a little unclear what that's ultimately going to look like. Maybe even scarier is when we know where we're supposed to go, but we just don't know how to get there. And it doesn't even seem sometimes like there is an actual clear path for how we're supposed to accomplish that transition. And, you know, to sort of sum those pictures up, it's difficult. Healthcare transition is difficult. And that's that way for a lot of reasons. You know, in the big scheme of things, the healthcare system was not designed with certain populations in mind, meaning the healthcare system is quite siloed in a lot of different ways. It's fragmented in a lot of different ways, but particularly the pediatric world and the adult healthcare world are very different from each other. They're very distinct from each other in a lot of ways, culturally, and how things are practiced, the processes, the insurance and what's covered and what's not, the supports that are there or are lacking. All of these things are very different from one side to the other. And there is not much in between, or at least historically has not been much in between to bridge the gap between those two worlds. When you think about that process and those systematic, ingrained difficulties from the different points of view, it becomes even clearer why it's hard. You think about it, of course, from the patient and the individual and their family's point of view first. This is tough, right? You've gotten to know your pediatricians and specialists over the course of, maybe even 18, 20 plus years. And all of a sudden you're supposed to just say goodbye and go find different people when you're probably perfectly happy with the people that you've gotten to know and trust so well over the years. That's a hard ask. And it's no easier, I would say, for pediatricians to say goodbye. Those relationships are really important, and you've gotten to know patients and their families and help to sort of shepherd them from maybe the initial diagnosis, through potentially some tough years and tough moments. And you've really built up a bond and worked really hard to keep people as healthy and happy as they can be. And so to just kind of say goodbye and hope that the next group of doctors cares as much as you do and does as good a job as you've done, that's a kind of a daunting period as well. From the internist side, a lot of internists do not have maybe as much training or know-how on a lot of the sort of conditions and related topics that come up for individuals with IDD. And just the world is a little bit different. There's less supports and less time and less things in place that might make it easy or easier to care for potentially medically complex individuals and sort of all the other things that might come with taking care of individuals who have maybe different needs from certain other adult patients. Emerging adulthood, so I use that term as a developmental period, as you're kind of leaving adolescence and becoming an adult. There's so many things, as we hopefully can all remember what that's like. There are so many things changing in that period anyway. So, more hormonal changes, and we want to be more independent, and school is ending, and we're trying to figure out what's the next steps, and maybe siblings are leaving the house or coming back or having babies and getting jobs. And just there's a lot of change in this period. And that change can be really destabilizing and difficult, even when you remove the aspects of people's health and health concerns. Just the basic layer of that developmental life period is really challenging. I alluded to this earlier when talking about the systems in general, but there's a lot of change in supports, particularly for people who have Medicaid and are switching from pediatric to adult Medicaid. A lot of things drop off or decrease, maybe in terms of nursing or home health, or even just access to certain therapies and things like that. These things change and make it a lot harder when you lose the support you're used to. And then there's other considerations that we'll hopefully have time for at the end that are more related to people with IDD, including medical decision making and long-term care planning and other topics that are really, really important for the future. Oh yeah, this is a picture of a big box of records, which sometimes internists get, and that's kind of daunting. We'll talk about that. I don't think I mentioned this in my introduction, but myself, I am trained as an internal medicine and a pediatrician, the dual training. So I take care of adults, and we'll talk more about my clinic, but I do have full training in the pediatric world. So I do have a sense of what these two worlds are like, and how they differ, and how maybe they can be glued together better. So transition is hard from a lot of different perspectives for a lot of different reasons. How are we doing to address the difficulties, to address the challenges that come up during this period? In short, we're not doing so great, although maybe we are improving. One way to look at this, and I don't think that this is by any means a complete take on the situation, but getting high quality and largely representative data for the country at large is tough for these topics. So this is kind of what we have. So this is based on a national survey of children's health, targeting kind of the whole country, random sample, and they asked 3 questions, which was, did your child's pediatrician talk about the fact that you are going to shift to adult care in the future, in your future? Did the individual, the patient themselves, have a chance to talk to their doctor independently? And did the doctor help develop and work on self-care skills or healthcare changes? So, hey, let's talk about how you might call to get a refill. Let's talk about how you might manage your, blood pressure issues, or take your medicine every day for your thyroid, or constipation, or whatever. So these were the 3 questions, and when those were asked to a representative sample, only about 20% said yes to all 3. Maybe that number was slightly higher for people who had more kind of severe disease. But the bottom line is that even these sort of really basic measures are really not taking place. So I would say we're not doing great. If you look at other outcome measures, I wouldn't say that they look a whole lot better. And there's other ways to think about transition in terms of, is it being, is it successful or not? One is very important, is just the experience, right? So from a patient and family perspective, how does it feel? Does the process seem supported? Does it seem like you're just being thrown out there? Do you feel like it's successful, right, in terms of your experience? The second one you could think about is just health outcomes, right? So like, let's look at someone who has diabetes, like their lab measures of diabetes. Do those get worse or better, or stay the same in this transition period? And then third is value. We're spending money to help with the transition process, but is it actually helping? Is it making a difference? And how much bang for a buck are we getting? So value is important in a finite world with finite resources. And there's data to look at all of these different types of outcomes, but on the whole, we have some work to do. So let's shift gears a little bit here and talk about how we in our clinic, in my clinic, address healthcare transition. So we're the transition medicine clinic. We are a primary care medical home. So even though we are named the transition clinic, this is not a bridge. It's sort of a destination, but we help people in that transition period. But you can stay here. So people stay there, and we take care of people of all ages once they reach adulthood. So we start around 19 years old, but we have people up in their 40s, 50s, 60s who've been around for a long time, or maybe got to our clinic a little bit later in life. We see people with intellectual and developmental disabilities of all types. So we do have a handful of folks with SMS and other genetic conditions. And then we see a lot of people with autism and cerebral palsy and spina bifida and things like that. We have a really awesome, pretty diverse team. We have 7 physicians, 2 nurse practitioners. We have 4 nurses, 4 medical assistants, 3 social workers. And then we have people, students who come in all the time, whether it be medical students or medical residents, nursing students, social work interns. We just have lots of people rotating through our clinic to learn about what we do and to get more exposure and experience with this population. And we're very collegial and team-based, so we don't even have I don't have my own patient panel. We all share the entire patient panel which gives a lot more flexibility to our patients and really allows us to learn from each other and to make sure we're doing the best job we can for everyone. We do get enhanced support. So my normal visit time is 30 minutes, and for a new patient, we get 60 minutes, which is a lot longer than your average adult primary care. And I get an additional time outside of clinic to make sure I'm following up with patient-related questions and lots of paperwork, as I'm sure some people know. So making sure we're taking care of all those things in a fairly speedy manner. I talked about our mission to teach and how important that is. And then we're called the transition clinic because, like I said, we do a lot of work, especially when patients and their families initially first get to the adult world. We do a lot of the planning and the mapping out of what's the rest of the things going to look like. You got your primary care set up, but what about your specialists? What about your insurance? What about your vocational questions about school and what's after? We do a lot of work in that area. And then in terms of looking at the bigger picture and looking more towards the future, we are involved in some research projects to really better understand, what's the best way to do this? What are the things that we don't know? And there's a lot of things we don't know. And this is a very under thought of area of research that is just starting to take off a little bit more in recent years. Okay. So we'll pause here. I don't know if we have any questions so far, but we got through our first two. We reviewed some of the challenges that are commonly faced. We described at least one clinic and some very 50,000 foot view of how we do things. But our next stage we'll go through, I think, is really kind of the meat of this talk, which is to develop a framework for the transition process that breaks things down into smaller chunks and helps us think about what a prospective person, individual, or family might think about as the transition, from the pediatric to the adult world looms. What are some things that we think about? What are some things we can tangibly do to make this process smoother? While we all work and wait and hope that the systems at play will eventually facilitate this a little bit better. But in the meantime, we can take a lot of this into our own hands. Okay, so let's keep going. So another bridge picture. I think this is the last bridge we'll see. I like this picture. One, because maybe it's less scary. It's kind of a cute little bridge, so it's not quite as daunting. But most importantly, it has three parts to it. So it's a good analogy for how I break down transition. The first one, kind of leading up before you're actually crossing over the stream, think about that as preparation. So this is really what happens in the pediatric side of things. This is how all the work we do to get ready for that leap into the new world. The actual leap itself, where we go, actually make the act of crossing from one side to the other, that's the transfer. So that's where we're actually going from one world to the next. And this is usually the sort of shortest one. Whereas preparation can take a long time. And then the last part that sometimes is forgotten about is integration. So, okay, great. We had our first visit or whatever on the adult side, but it might take a while to actually fully be in the world and have everything smoothed out and everything kind of settled. And so that's the integration piece on the adult side. So we'll talk about each of those pieces and the components of each. So starting with preparation, some things to think about. When you're thinking about what and when the transition might take place with any given doctor, it's important to have these discussions. Now, ideally, doctors in the pediatric world would be thinking about this and having these discussions, and it would just be seamlessly integrated into your care. But in reality, this is usually not the case. So it's important to initiate these discussions, and some things to think about or even ask. You can just ask, when are we going to get kicked out? When are we going to have to start seeing an adult doctor? When should we start looking for one? And you might get a variety of answers. I think it's nice if clinics have a policy. And if they have a policy, then you kind of know what to expect, right? And in some countries, like in Canada, for example, this is a strict thing. So at 18 in Canada, pretty much without exception, with very few exceptions, people leave their pediatric whatever doctor and go to the adult world. In this country, it's a lot more flexible, but that also leads to a lot more uncertainty. And it's not always evenly distributed, even in the same clinic or in the same hospital system. It can be really variable. So asking, what's your policy, or when would you expect us to go transition to an adult doctor? Now, sometimes you will get the line about something like, "Oh, well, you guys are the best, and I'll see you forever. You never need to leave." Well, that's really kind, and I think that in some cases maybe that's the right answer. Which that's a whole nother discussion. But typically that is not practical for a few reasons. Even if the doctor's okay with it, um, sometimes the insurances that you'll switch to when, after 21 will not be accepted by the pediatric hospital. Sometimes the hospital system or clinic itself might have policies about what's okay and what's not. That doctor may eventually retire. And then honestly, depending on the medical condition we're talking about, it may not be in everyone's best interest to see a pediatric doctor when you're an adult. And that's nothing against the pediatrician or their kind heart, but they may not have the right training or know how to be thinking about the things that might apply to an adult. That's just part of their training. So, I think there are some exceptions, like I said, but in general, I think it's good to at least have a plan for when that transition is going to take place instead of just kind of letting it hang out until something happens, because then you can't plan, then you can't prepare, then you can't go find someone, and you're just all of a sudden you might be left without the care that you need. Another question that I think is helpful to ask is to ask for recommendations, right? Especially if you're seeing a specialist for a very rare condition, that network might be pretty small. And so you might ask, hey, in this city, do you have any adult cardiologists who you'd recommend who would be familiar with this condition, or practice who is really respectable that you trust? And you might not get any answers, but you might get some leads, and sometimes you'll get really good recommendations that way. And I do recommend starting early. There's no harm in starting way before you need this information, but it's much better than starting too late. And I really don't like when I hear this, and it happens a lot. Patients will come in and they said, "Oh yeah, I just saw my neurologist, for example, and they told me that was my last visit." I'm like, wow, did you guys prepare at all? Was this sort of a surprise? And they're like, yeah, we didn't know. It never came up, and now we need to find a new neurologist. Ideally we would have known that ahead of time, already had a plan in place, already had an adult doctor in place. So starting early hopefully avoids that situation most of the time. I think those are the really highlights there, but I think it's also helpful to sort of reflect for each doctor you're seeing what role they're filling and where that particular medical condition is in the big scheme of things. So another way to think about this, let's talk about neurology, and let's say somebody has seizures. Is this a situation where everything is really, rock steady, and yeah, we had some seizures as a kid, but we've been on this medicine for a long time and things have been just perfect, no seizures in years and years and years? Well, that's kind of an easy transition. We just need to find a neurologist to make sure that we can get those medicines prescribed, and or maybe someday wean them off. But it's a very different situation if you're seeing somebody, and or say again, neurology, and you're having uncontrolled seizures and you've been switching medicines left and right trying to get a hold of things. That may not be the best time to transition, at least without a much more dedicated discussion and plan and the details all in place. So I think it's important to kind of reflect on where things are at. Window of opportunity. So there are some situations, and these might vary depending on where you're at in the insurances at play and the systems at play, but there are some medical conditions that are best addressed in the pediatric world. A good example, at least locally here, it is really challenging to find adult orthopedic doctors who address scoliosis, for example. So if surgery for scoliosis, so big surgery, spinal rod fusion, the whole bit, if that's on the table and that might need to happen, it's really, really preferred to have that happen on the pediatric side as opposed to the adult side. So there are things like that where, like, if it's going to happen, you really need to think about addressing it now. it's hard to know those things. And these are lessons that we've just learned from uh, experience along the way. So I think if, it's good to have someone who kind of is aware of those potential pitfalls. But again, I think discussing the bigger picture about where things are headed and what this might look like in 5 years with each doctor can be really enlightening, and may lead to different decisions, or at least different considerations with the timing of things. A few more things about preparation, and I do think that this is kind of the bulk of what a lot of people want to know about. So there are a lot of insurance, or at least notable insurance changes that take place in this period. Medicaid is a big one, and I think that is worth discussing, since a lot of people with IDD are eligible and have Medicaid. So just to quickly walk through it, and this is like a whole nother talk itself, but the requalification process, if you have pediatric Medicaid and you want to get adult Medicaid, you have to go through a requalification process around age 18, at least in Texas. I don't think that varies a whole lot. But the adult Medicaid doesn't actually kick in, or the pediatric doesn't switch until age 21. So 18 is when the requalification starts, and then 21 is when it switches. And there are a lot of changes, and these I'm sure vary state by state, but at least in Texas, where I practice, a lot of the things that people are used to getting covered. So for example, ongoing physical occupational therapy to address a variety of rehabilitation needs are routinely covered on the pediatric side. They are not covered on the adult side, at least just by Medicaid itself. There are other ways to get them, but not by Medicaid. And then there are a variety of options. In Texas, we have a variety of managed Medicaid plans. So a company like United or like Molina takes the state money and then runs the Medicaid program. And you can choose which program you want based on what's available in your zip code. And that's just good to know, because depending on where you want to be in the adult healthcare system. So for example, if you want to come to my clinic, you do have to, that limits your options in terms of which plan you might be able to choose and which plan might be covered by the place you want to go. And then in terms of other insurance options, many people also have a private plan. Some people even have a Medicare plan that most of the patients I see are on Medicare because they are able to get on their parents' Medicare plan. They don't qualify for Medicare themselves. And most people are aware that dependents can stay on a parent's plan up till 26. Not as many people know that you can actually stay on that plan for private insurance or Medicare past age 26 if a person has a disability that prevents them from being able to kind of support themselves entirely. So that process requires a physician certification, but we do these all the time, and it's not too big of a process. So keep that in mind. If you do have a private plan that you want your child to be on, they could potentially stay on it for the rest of their life, depending on the situation. Outside of insurance, I really hope that a lot of people here have heard about Medicaid waivers. If not, this is something that I really strongly recommend asking your doctors about. So waivers are in place to kind of cover the gaps of the things that insurance, particularly Medicaid, does not cover. And so things like adaptive equipment and home nursing and other supports like that are often not covered, or not covered as fully as we need them to be by Medicaid, can be picked up by the waiver program. They also pay for day hab and group home, things like that. They can help with that. The main issue, and the reason why it's so important to talk about these things like now, if you've never had before, is because there's often a big wait to actually receive these services, even if you qualify. And that wait time, again, varies by state, but just as an example, Texas, everything's bigger in Texas, including our wait list. I just, but it is very frustrating. The wait time here is 12 to 15 years. So very important to get on those lists as soon as possible. Other states do not have near as long of a wait, but some states you do have to wait quite a while. And then lastly, I'll just say, the other kind of the big homework assignment in this preparation phase is to really work on building knowledge and independence. And, as a parent myself, we're doing this constantly all the time and trying to just build up people and help teach and help allow for, guarded mistakes, right? That's the best way to learn. And so really working on what that looks like from a healthcare perspective. So having people learn what their health conditions are and being able to talk to other people about them. What's your family history? What are your medicines? Of course, up to what people are capable of, but I'm really trying to fully build out that knowledge and independence as much as we can. Okay, so that was the big first chunk of the bridge here. We're moving now on to transfer. So again, this is that act of now you're finally in the adult office for the first time, in the medical office. So before the visit takes place, a few things to think about. I personally think it would be a good idea to go to where your new doctor is, maybe ahead of time, especially if somebody might have some nerves going to a new doctor, visiting a bunch of new people, which is very common. Going to the place first can take some of the nerves away, especially if it's far away and you're having to park in a big new medical center. Like, a lot of people get lost going to my clinic. And are a little bit late, and then everyone's sort of stressed. So going ahead of time, if that's feasible, if that's possible, can really make things go a little bit more smoothly and less stressful. If there are certain accommodations that are needed, it is helpful to try to let people know of those ahead of time if possible. Now, in an ideal world, every clinic would just ask when you scheduled, hey, are there any accommodations we need to be aware of? Almost like a high-end restaurant, where you go and you're like, oh, do you have any food allergies? Do you have any preferences or aversions or whatever? Like, these are just, I think, really humanistic things that I hope will be more prevalent in the practice of medicine and as we move on. But as it stands, I know a lot of places do not ask these things readily. We do at least an intake for our patients who have a diagnosis of autism, since sometimes those accommodations can be really make or break. But I think, in reality, we should probably expand that to all of our patients. And, we at least are open to accommodations when they're needed or requested. And then lastly, transferring records is really important. So I did bring up that big box of papers. That's probably not the preferred way to get a bunch of records these days, though we do get them sometime. Because, it just takes a long, long time to sort of sift through everything. And the hardest one is when you get the box like during the visit or even after the visit. It's really helpful to have it ahead of time so you can kind of prepare, know what to ask, know what to think about. So getting those ahead of time if possible, or requesting those from your pediatrician or the specialists can be really, really helpful. And we'll talk more about maybe a better, a summary, which is a whole separate item. At the first visit, so now we're there. If you can, I personally think it's very helpful when people actually bring the medicines that they're taking. Sometimes we can kind of match what the pharmacy information is, or people might be able to sort of say it or tell it. And I guess a detailed list is, pretty much the same as actually bringing the medicines, but the more details, the better, because, especially if you're wanting the doctor to take over some of those prescriptions, we can't really do that if we don't know exactly what it is that you've been taking prior to that visit. So bringing the medicines or a list is very helpful. A list also of the doctors you see can be very helpful, especially if we need to get records or contact them for some reason. So knowing who's part of the care team helps us to map out any other transitions that might need to take place, as well as just sets up some channels of communication. And then lastly, I think having a summary, which doesn't need to be any longer than a page, 1 or 2 pages, whatever, can be really helpful. So I have a whole page on that. So trying to get that whole box of records distilled down to the kind of the salient points can just really expedite and help that first visit go much more streamlined. This is, I think, a really key point here. So what might you put in the transfer summary? Now, this isn't any kind of priority order, and this is just my take on it. I'm sure there's other sort of summary templates out there, and it can look like a lot of different things, but some key pieces that you might think about. Okay, we already talked about the care team, which doctors do you see? We already talked about the medicines. Allergies are important too. A general sense of the medical conditions. Now, that doesn't have to be every detail of everything that's ever happened, but I think, ones that are being actively treated with a medicine or actively followed by a specialist, I think would certainly warrant mention. Surgeries, again, maybe not every surgery you've ever had. If it's like a really minor, like, oh, they had the ear tubes, on 10 different occasions, maybe just mention ear tubes, and that's probably fine. But I think sometimes having a big surgery or notable surgery that required anesthesia is an important thing to know for for a variety of reasons. Having a sense of communication and function can be really helpful. We actually have a questionnaire that we send out ahead of time that helps us get a sense of somebody's adaptive abilities. What things do they need help with? What are they able to do independently? It doesn't have to be a long written out thing, but just a general sense of, here are the salient points of what people need help with, or what they're able to do independently. Gives us a real good sense of someone's abilities and where we're starting from. Maybe a mention of what supports are in place, or who the person lives with, who's in their family. Any kind of durable medical equipment or supplies can be helpful, especially again if the doctor you're going to see is going to be the new person ordering those things. Having that information is helpful, because we got to have that info to be able to order things and manage them. And then if there's anything that's really been important lately in terms of hospitalization or a severe medical condition lately, I think that might be worth mentioning, whether you put it in the summary or just mention it to the doctor, because that may be something that kind of skips line to the front of the line, something that might need to be addressed, maybe even before some of these historical things, depending on the importance of it. Okay, so that's transfer. And then the last part of the bridge is integration. So you've had your first visit. As you start these conversations with your new doctors, what are some things that you might bring up that you might want to discuss? I think it's important to clarify, make sure that everyone's on the same page about what the visit reason is, or what the thing is that you're hoping to get out of that relationship. So, and I know that sounds pretty intuitive, or at least it might, but it sometimes is not. And I don't know why this is, but sometimes I will, for example, refer a patient to a specialist for reason X, Y, Z, whatever, and then they'll come back and I'll look at the note, or I'll ask the patient, their family, so how is the consult for your really, really bad reflux? And they'll come back and they go, oh well, we talked about constipation. Like, well, okay, that's important, but what about the reflex plan? And they're like, yeah, it didn't really come up. It's like, okay, so I guess the point of that is that I think making sure that everyone's on the same page about what this doctor is going to manage. And sometimes this gets tricky too, because just because you see a neurologist doesn't mean you're seeing a headache specialist. Maybe you need to see a different neurologist for headaches compared to the neurologist you see for seizures or something like that. So really making sure that what this relationship is meant to be for both of you. So sometimes clarifying that in a really explicit way can save a lot of headaches. And if that is maybe not the person you were trying to see, like maybe this is a headache doctor when really you need to see a seizure doctor, even though they're both neurologists. You might even ask, like, do you think this is a good fit? Do you feel like this is that you're going to be able to address the problem that we need you to address? And I think there's a kind way to ask that, but I think it's important to just be blunt about it sometimes, because the last thing that everyone wants is to have a working relationship that's not a good fit, and maybe nobody wants to admit it, right? Maybe the doctor doesn't feel comfortable with XYZ condition. Maybe there's a colleague of theirs that would be a better fit. Now, that doesn't give people a free pass, if they need to step up and just take care of the issue, or to find someone who can. But I think if you get the vibe that maybe this is just not the best fit, I think it's always okay to say, do you think that this will be a good fit for all of us? And if not, is there someone that you could recommend who might be better suited for it? And then, bring your summaries to whatever new visits you're going to, specialist or primary care. And I think it might be helpful sometimes to include some basic information about SMS. This isn't the most common genetic syndrome, as I know we're all aware of. And yes, in an ideal world, people would know where to look and get this information on their own. And a clinic like mine, I think we're pretty good at accessing information about a variety of genetic syndromes fairly quickly. But that's not always the case. So I think having information at the ready might be very helpful, particularly if you feel like it's someone who maybe has never met an individual with SMS before. And then, as we continue to age into the adult world, that doesn't mean we stop with our building, right? We don't stop with knowledge or independence or skills. And so I think that's really important to continue working on that. The work doesn't stop just because you've made it to the adult world. And then lastly, reimagine the possibilities. So I put this one in because I feel like I've heard enough stories in my time as a physician about all the ceilings, all the limitations that were very firmly put in place by people in the pediatric world. And I don't mean that in a judgmental way. I understand that as a pediatrician, we're often asked really difficult questions about expectations and really difficult questions about predicting the future, and what people might be able to do down the road. And, I think trying to give your best guess and estimate based on your experience, like, yes, that's worth giving. But I think sometimes those limitations are put on a little bit too firmly without leaving open the possibility that not everybody follows the rules and that things might change in the future that we don't expect now. And so a lot of times I hear people come in and they said, well, my son or daughter, they told them that they weren't going to live past a year, or they told me that they weren't going to walk, or they told me they weren't going to talk, or they told me they would never go to school, or whatever. Pick it. I've heard it. So I think it takes some unlearning along the way to say, well, maybe we need to reimagine what is possible, because what wasn't possible certainly has been proven otherwise. So I think trying to step back and the transition to the adulthood is a perfect time for everyone to step back and reset and say, based on the information we have now, not what we had, 15 years ago, what might be possible. So that's, I think, a really important part of facing the adult world. I do see there was a question here.
Yeah.
So let's see. Do you see patients in your clinic who are already receiving waiver services? I do, yes. So I don't have a great percentage off the top of my head. I would say more people than not are either on the wait list or are not aware of waiver services. But I do see a decent chunk, maybe ballpark like a 33% or so of people who are established in our clinic who are already receiving waiver services. And when they attend with agency staff, how does this usually go? Pretty good. So we do have a handful of people who are living in group homes, or maybe go to a day program and come in with a day program staff, and maybe even with a parent at the same time. The way I look at it is, more information is never a bad thing. So I try to get history from all the involved parties to really get a more complete picture of what is going on. The times that it can be kind of tricky is if somebody is living in a group home and they come with a staff from their home who is maybe not as involved in the care. Sometimes that information about what's happening and the important things I need to address is very limited. And so what I'd recommend to make those visits more successful is, whoever is going on that visit should be somebody who can really give you the rundown of what's been going on lately. And that doesn't mean you can't call other people in, but it's nice to have those instructions. I need to know, who should I call if I have questions, or who should I make sure that we call into the visit who can give us that information about what's been happening lately, if the person who's there is more of just someone who helps to drive and transport and things like that. But yeah, thank you for that question. That's a really good question. And I'm glad people here that work in the waiver setting are present, because that's such an important role here. Okay, so going back here to the next slide. So I think that is kind of the meat of the talk. And we're going to now go into the last part here where we're going to talk about some considerations. Now, I don't think we're going to get through all of them just in the interest of time, but at least kind of leave them up here and hit some highlights. And then I want to make sure we leave some time for questions in our last 15 minutes or so. Medical decision making, I think, is one that comes up enough. It's worth its own slide. When we think about this from a medical side of things, we think about the word capacity, which is somebody's ability to make a responsible decision. And I think that this is a very fluid concept. So if you think about, people can take medicines or drugs or alcohol, that changes one's ability to make responsible decisions. So this isn't a static thing. And sometimes people have conditions that change one's capacity over time. So, dementia is a good example. Somebody might, in mild dementia, still really understand and be able to make decisions on their own behalf. But as that progression happens, they may be less and less able to make that. So this is a moving target within a certain day and over the course of a lifetime. When we think about this again from the medical side, we are thinking about somebody being more autonomous or requiring more support. You may be at one extreme end, somebody doesn't have any supports at all. I don't think this really exists unless you're living in the wilderness by yourself. We all have supports. We all have loved ones that we turn to for advice and for help. So most people have informal supports regardless. And then there is in some states an entity called supported decision making that I think is really important to consider and to look into for people who might need more dedicated support, right? So you want to make this official. So this process is pretty easy, again, for the states who have it. In Texas, it's really just filling out some paperwork and having it notarized. So it is, again, it's official, but it's quick. Compared to guardianship, which is for anyone who is aware of that process, is long and requires the courts, requires usually thousands of dollars. It's a much more intense process. The reason I have this red line on the slide between guardianship, whether that be just guardianship over certain areas or over sort of everything, compared to the non-guardianship options, is that when you start talking about guardianship, and again, just to define that, we're all guardians as parents when our children are under 18. But once they become 18, they become their own decision maker. And so at the end of the day, if they wanted one thing and you wanted another, there's sort of no way that you could, there's no legal way to sort of enforce that unless you obtain guardianship. And by doing that, you're petitioning the courts and saying that this person does not have the capacity to make responsible decisions. So therefore, I want to be their guardian and make those decisions on their behalf. And sometimes, that is the right thing. And you could have, a whole discussion about this. I've written about this, the ethics of it. This is a tricky topic. But the thing, I guess, to know if you're faced with that decision is just to know that people who, when a person, if a person has a guardianship in place, the person does lose some rights in the process. So usually that means they cannot vote. They may not be able to marry without, again, sort of signing off from the guardians. They may not be able to drive a car or decide where they live. So there are some trade-offs for that. So this isn't to put any judgment value here, but just to sort of highlight the importance and the stakes that are involved for this process, and to know that there is an alternative called supported decision making, again, in most states, that might be an alternative, at least worth trying or talking about for certain people, depending on the situation. And then I won't go too much into this, but long-term care planning is a really important topic. I actually am involved in a pretty big research program right now addressing this issue here. So thinking about the future and about finances and living situation and what's going to happen to my loved one in the future when I may not be around anymore. And this is important for all parents to have that kind of plan in place. But again, for adult children with IDD, there might be additional considerations or things that we have to plan for. And this is hard to talk about. I get it. This is really hard to plan for. But again, we're looking towards how to better do that for people who need it. Some other random miscellaneous wisdom that I'll just throw out there. I don't know if wisdom is probably too strong of a word, but experiences, again, from my clinic. Everyone is constipated. I'm just going to say that, period, hard stop. Maybe not everyone, but most everyone. And I know this is sort of a topic that leads to some giggles, but really, this is one of the most common things I talk about by far in my clinic. And I think it's under-recognized and it's not always obvious. Of course, those two things are probably tied together. It can show up as a lot of different things. So just make sure we're thinking about this, make sure we are talking about this with your physician. And just remember, it doesn't always look like the obvious, oh, I haven't had a bowel movement an entire week. Sometimes it's a lot less clear than that. Another thing is just to know your baselines. And I think this is very intuitive for most parents. When you can tell, usually when you walk in the door, oh, I think you're getting sick. You just have that look in your eyes. You just don't look like yourself. You're not acting like yourself. Most parents are so in tune to that change from the baseline. I find so much value in that when I'm talking to families of the patients that I'm caring for. But not everyone appreciates how important that piece of the history is. So if you feel like your son or daughter is not how they were before, really making that point stick and drive that point home when you talk to the doctors and say, listen, I understand that this is, their vitals are normal. I understand their labs are normal, but they're still not normal. And maybe this isn't an acute thing that you have to figure out today. But if things don't seem normal, it's okay to still really advocate and say, like, listen, I understand that they're not in imminent danger, but like, what is our plan? Even if that plan is just to continue to closely watch, but what is our plan to make sure that we are not just ignoring the changes that we are perceiving, even if those are really subtle? Behavior is communication. I have 3 very young children at home, and I can tell you this evening has been very clear already that behavior is communication. So when people have behavior changes, what are they trying to tell us? And we all do this. We all, road rage, right? Like what is that behavior trying to tell us, Paul? It's probably telling you that I'm frustrated that traffic in Houston is so bad, and I just want to get home without having this really, really extra long commute today. Okay, well that's why that person's honking. But we don't always think about it that way. And so sometimes when people go to the doctor and they have a behavior change, the first discussion point is, what are we doing about medications? Or what are we adding? Are we increasing the medicines we're already on that sort of address behavior? And don't get me wrong, sometimes medications are literally life-saving and absolutely necessary in the right situation. But what we really need to be thinking about, first is, what is this trying to tell us? And sometimes what it's trying to tell us is we need to think about what else could be going on. Maybe the constipation I talked about, and that's a big way that people come into my clinic, where we don't know about constipation. Well, they come in and they're just really having some behavioral challenges lately, and then we go looking for it, and lo and behold, they actually are constipated, even though it's not obvious. So just thinking about what those behaviors are trying to communicate to the rest of us. Put your mask on first. So I hope that someone has said this before, but I think saying this to all parents is important, particularly parents who are caring for, I guess anyone, but adolescent, young adult who have IDD. I think you have to take care of yourself to a certain degree to be able to take care of others. So having some insight into where your limitations are, or when you need help, when you need a break, and hopefully having enough of a support network to be able to say, I need help, I need a break, I need to tap out for a second. Because we can't effectively care for others if our own least basic needs, if not our secondary or other needs, are being met to some degree. So having that awareness, and it's not selfish if that's the way to take care of other people the best that you can. It's not selfish to ask for help. It's not selfish to need a break. It's not selfish to go take that vacation, because you're going to be a better caregiver and parent after that than if you keep putting off your own needs for too long. And then lastly, trying to build up your team, especially in that preparation phase, and as you transition over, trying to build up your team with the right doctors and know who to talk to in your insurance, know who that social support network looks like. Those are all just crucial pieces as you go forward. Okay, I'm gonna pretty much skip this slide so we have at least a few minutes for questions. But I guess the big takeaway from this slide is that it's really, I think, hard sometimes to find doctors who, quote, get it, the good ones, right, who understand, who have maybe experience, or at least some patience and flexibility to acknowledge that everyone's different and everyone has different needs, and that we need to just be a little bit more accommodating to meet people where they're at. That can be really hard. And there's no one good way to sort of find the doctors that I think we're all hoping to get for ourselves and for our loved ones, particularly if they have some of the needs that we've been talking about. But I think, talking with other families, going on the, local, Facebook or whatever groups to sort of get the word on the street, if you will, about, what are some doctors out there who really get it. Talking to parents in prisons and trying to find other doctors locally. This is hard, but trying to investigate and explore all avenues to try to find the right doctor can really go a long ways. I will say that the future looks brighter, and I know our clinic is trying really hard to make sure we train and educate as many healthcare professionals as we can to make sure that there are more and more doctors out there and other healthcare professionals who do have some experience and competencies to be able to provide high quality healthcare to people of all needs and backgrounds. All right, so just really quickly to sum up before we turn over for questions, healthcare transition is tough. Thankfully, there's a lot that we can do to smooth the process while we're waiting, and while lots of good people are working on making this process better on a systems level. Make sure you're building your own teams using what supports are available, but advocating for the rest. And sometimes that advocacy is a long and hard fought battle. Building support and independence is really crucial throughout this entire process. And again, this might involve some unlearning or at least some reimagining of what can be and what could be. And really just don't stop dreaming of, again, what can be, both at a personal and individual family level, but also just a better future for everyone, as we really advocate to try to make this entire transition process and entire healthcare system better and work for all of us better. Okay, that's all I have. Yeah, I'll leave these resources up for anyone, as well as my contact info. So feel free to reach out with any other questions. And I'm certainly happy to answer questions now with the time we have.
Great. Thank you so much, Dr. Behrens. That was a really great, very in-depth, fantastic presentation with lots of really great tips for parents who are transitioning to adulthood. And I know that your patients must really appreciate everything that your clinic does to make that transition go so smoothly, or more smoothly. So thanks for sharing your knowledge and all of your tips with us this evening. Really appreciate it. So we do have a few questions for you. Let's see, we'll start with behaviors as IDD adults can be so concerning, and although there could be physical discomfort somewhere, do you see mental distress becoming harder as they get older? It seems that although our children are developmentally challenged, their behaviors can become very aggressive.
Yeah, so aggressive behavior is a really challenging topic. I don't know if there's much data to say that it becomes more common as adults. I'm just not familiar if there is. I think what ultimately happens is, even if the same level of aggression is there as an adult compared to, say, a child, the stakes are just a lot higher for adults because people get bigger and stronger as adults. And so even if, like, as a kid, if my 4-year-old kicks and screams and hits, like, I can pretty easily diffuse that. If I have a 21-year-old young man who's pretty big, that kicking and hitting during a tantrum is the stakes are a lot higher. So whether the overall amount of it is more or less, I don't know, but I can say yes, the stakes get a lot higher as people get adults. The other thing I'll add to this too is I see a lot of behavior changes and sometimes aggression with it happen in the few years after school ends, particularly for individuals who don't have something else happening. So people in school, and like, it's understandable, you don't necessarily have to jump right into the next thing, whether that be a day program or some more, college courses or a job or volunteering or whatever. But for people who don't have a plan and just sort of stay at home without anything, like, their sleep patterns change. A lot of times they can get depressed or bored, and so sometimes behavior changes come in that situation too. So I see that really commonly. So aggressive behavior is really challenging, and I do think thinking about not just the situation, right, are they getting their needs met in a sort of big sense, right, in terms of fulfillment and purpose, but are their physical needs being met? Is there discomfort? Is there something else going on? And that's where a good primary care physician is worth their weight in gold, because they can be thinking about the bigger picture and maybe do some testing to make sure that something's not being missed.
Great. Thank you for that. I can definitely see mental distress happening through these major changes in life and changes in program. That makes a lot of sense. Let's see. So the next question, we'll move on to the next question, is there anything being done on a broad net or national level to address some of the shortcomings faced by so many individuals transitioning to the adult healthcare system?
There are, there are a lot of working groups. There's an annual conference in Houston that's dedicated to healthcare transition for people with kind of special healthcare needs. So there's a lot of really, really smart people working on that kind of issue from a lot of different angles, who present some of their findings at that conference. Another thing that myself and my team have been actively trying to build in the last year is to trying to form a network of healthcare providers who take care of adults with IDD. Because I think it's really hard to know, because it's not a specialty in itself. And that's part of the problem. You know, it's not like you just go to a GI doctor. There's not like adult IDD doctor specialty. So we're addressing that in a few different ways. We do have a sort of pilot fellowship program where it's an additional year of training after someone's done with their residency to get more skills to be able to do a good job taking care of adults with IDD in a primary care setting. So that's one thing we're doing. We have had 2 fellows go through, and we have 2 more coming to our program next year. And then we're trying to build a network, like I said, of just identifying who's already doing this out in the community across the country, which has been really cool, because we've seen a lot of people come out of the woodwork. We had no idea that, they've identified themselves and say, I have a small group of patients with IDD that I see in my clinic, or we have a clinic that's totally dedicated to this patient population. So trying to build that network that will allow us to, 1, be able to kind of know where people are at, and then 2, start to ask them questions about what does this care look like, and kind of with that sort of numbers, right? Then we can start asking better questions and giving more information to people who are looking to start these clinics on their own. So trying to promote that kind of broader scale of information sharing, and hopefully build more of have more information to encourage more of these types of clinics to exist and open up.
Wow. Yeah, that would be fantastic. It's really important work. And yeah, thank you. Thank you for doing that. That's amazing. I hope that makes its way to my area by the time my daughter starts to transition.
Yeah, absolutely.
Yeah. Okay. So the next question that we have for you is, what do you think is the most important thing to look for when choosing adult doctors?
Yeah. I got at this a little bit on the, how do you kind of find the right ones? I think the things for me is just, are they open-minded to just meet us where we're at? And that can be a lot, that can mean a lot of different things. That doesn't mean that they're going to have a particular way of doing things, and they have to sort of follow what I'm doing, right? They don't have to just continue what I'm doing without adding their own input there, but just being open-minded to what that means, to sort of what they're bringing to the table, right? So even if I'm unfamiliar with sort of why are you on that medicine? I've never seen that medicine used for this purpose. Like, I'm not just immediately dismissive, and I don't just say, oh, like, that's dumb, don't do that. Like I curious, like, for anyone who watches Ted Lasso, it's like, be curious, not judgmental, right? So finding a doctor who is curious and not judgmental, I think can go a long ways, and be that first step towards forming more of a partnership. And yes, you're going to rely and ask about their medical expertise, but like, I've learned so much from my patients, and even from, especially from my patients who have SMS, they've taught me a lot about what I need to know about SMS. So like, this is a 2-way street, and we can all learn from each other. And so finding a doctor who's open-minded about learning about SMS or any of the other related issues we talked about today, I think is what I'd be looking for.
Thank you. Thank you so much. Looks like we do have a question that just came in. Okay, so the question is, will you look at hospice care as well to help providers help the IDD population and their loved ones when transitioning?
Yeah. So hospice care is kind of a tricky issue. I mean, I think if hospice is kind of immediately in the discussion, like around the time of transition, I think it's also worth asking, like, whether we really should be or need to be transitioning, because finding a whole new set of doctors when that process is kind of on the table is tough. And a lot of times I think you probably don't want to find a whole new set of doctors if that's possible. Now, if that's sort of down the road, or even in the sort of not immediate future, but maybe in the next few years, I think just sort of being very open when you first established in the adult world, saying this is going to be a discussion, this is going to happen here. We expect, here in the next few years, like, what are some resources? Where should we start looking? So just again, like we talked about with anything, having those discussions early and often, as opposed to waiting until they're kind of right knocking on our door, I think can really help.
Great. That makes sense. Well, thank you so much again for being with us this evening. Thank you for your time. We really appreciate it. And thank you to all of our attendees for joining us this evening. We hope to see you on future PRISMS webinars. Like I mentioned before, all of our webinars can be found on the PRISMS website under the Education tab. And also, please make sure to subscribe our channel, our YouTube channel, if you haven't already, and follow us on social media. And also, if you're not already a member of PRISMS, then membership is free, and it's the best way to stay up to date with all things SMS. PRISMS is a nonprofit organization. All of our programs, including our webinar series, are fully funded by our donors. So if you'd like to support PRISMS and the many programs that it provides to the SMS community, like our webinar series, our conferences, our peer-to-peer support, our SMS clinics, the patient registry, and much more, you can scan the QR code at the bottom of the screen and it will take you to our donation page. So this concludes our webinar this evening. I hope everyone has enjoyed our webinar as much as I have, and thank you again, Dr. Behrens. We appreciate you being here.
Thank you, everyone. Bye.